I thank Sudha Madam and Venkatesh sir for this opportunity. I'm here to discuss about iris fixation IOL. So IFIOL, I'll just go directly to the surgical part. So the options right now are we have secondary IOLs like SFIOL, IFIOL, and iris claw. And in all these conditions, in the main indications for doing a secondary IOL are absent or inadequate capsular support, secondary IOL for aphakic correction, and fixation of a decentered IOL. And most of the secondary IOLs that have been shown so far, the only procedure that makes fixation of a decentered IOL more easier is the IFIOL. So the main contraindication indications with the iris fixation is you cannot do it in case you have a large sphincterotomy or a dialysis, and of course in patients with uveitis it is completely contraindicated. So in preoperative evaluation, the most important point is to select a patient where there is a good visual improvement after aphakic correction. And most importantly, if there is any kind of a cortical drop or a nucleus drop or a vitreous hemorrhage, it is better not to do a secondary IOL procedure through the anterior approach. And any persistent ocular inflammation has to be first controlled and then only taken up for a secondary IOL procedure or IFIOL. And most importantly, in cases of secondary IOL, in case when you are going to place an IFIOL, like Haripriya madam had mentioned, we have to see the patient in full dilatation in the slit lamp itself. In case there is any sulcus support, we need to map the clock covers and plan accordingly in the OT. So the instruments required mainly are Kugel and Sook, which Haripriya madam had demonstrated its importance, 10 prolin suture and a 3-piece IOL. McPherson's forceps and as well as a good vitrectomy cutter. So IFIOL can be done as a single haptic or a double haptic fixation, and also it can be done as a primary or a secondary procedure also. So moving on to the technique, like the previous surgeons have explained, a good vitrectomy is important before we start. So here we are using a 10-0 prolin suture, curved suture, and then we are taking the bite from through the cornea into in the iris, and the bite between the two point of entry and exit needs to be 1.5 to 2 mm. And I'll explain it to you why it needs to be this particular measurement at the last. So once that suture is taken out, we make a paracentesis between the two bites, which makes it easy for us to externalize and do the knotting part. So having taken the bite, now how do we externalize the sutures? So using a Kugel and Sook, from the opposite side port, go underneath the iris, catch the thread at the loop and pull it out gently. Here again, like Dr. Vivek said, the interwinding of the sutures can be a problem while you are looping the IOL. So you need to make it separately, have it separate, neatly visualized. So while you are looping the IOL, the leading haptic will be on the right hand side. So you can see the loop going into the leading haptic. 3 loops, 3 throws are made, and then the knot is brought into the much closer to the haptic optic junction. And then the leading haptic is first placed underneath the iris. After which, the trailing haptic will then be looped. As you can see, madam is placing it underneath the iris, and then the second haptic or the trailing haptic will be looped. In the trailing haptic, we throw only two throws. One and 2 throws are gone in, and then when they are pulling it, you can see the knot going near the optic haptic junction. Now there was a question how to confirm whether the haptic has been entangled with the suture. As you can see, as you pull the suture knots, suture threads, you can see the IOL being lifted gently. This ensures and clearly tells the surgeon that the loops have gone and the haptic has been strongly secured. So now how do you externalize it? The trailing sutures are cut, and then using the Kugel and Sook, you are trying to make the loop thread come out through the side port. the side port, once it is externalized, it is trimmed to have an adequate length for making the knot. So trim it. Then just like your regular tunneling suture, you throw 3, 2, 1, and then you tie it. And here you should be very gentle. You should not tighten it too hard or pull it too hard, because the iris can get cut. And this is another reason why we need to have a measurement of 1.5 to 2 mm. If you take a bite that is very close to each other, then when you're knotting it out, the iris can get cut. And if you're having a knot gap which is more than 2.5 mm, and then you try to tie it too tightly, again, either the iris can get completely cut in that area, or what can happen is you will have a loose hanging haptic in that area, which can again cause a tilting of the IOL. All the lens can be very, very behind the iris, which will not be visually helpful. Then, as usual, you remove the visco gently and you can close the case. Here is the surgical video. That is a wet lab video that we showed. Now that's a surgical video. A sclerocorneal tunnel is made. Side ports are made. Good vitrectomy is done. And more importantly, use viscoelastic very minimally, because this more amount of viscoelastics can always cause problems while you're looping the IOL or while you're externalizing and tying the knot. So here you can see the bites being taken within 1.5 to 2 mm gap closer to the side port. Repeated on the other side, between the side port again. Using a Coughlin-scope, go underneath the iris, catch the suture loop, externalize it with the help of a McPherson's forceps, or you can use a Hoagland's hook in the other hand also. Once the loops are out, make sure they are not intertwined or sticky. This again can be there if there is more visco inside as well as on the cornea. The other side, it is repeated again. So now the leading haptic is first looped 3 throws. And now you should just pull the suture thread that is outside to ensure that it is coming near the optic haptic junction. Then the leading haptic is then pushed underneath the iris and kept in position while the trailing haptic is looped. Two throws, and then the suture is pulled and the knot is brought closer to the optic haptic junction, and simultaneously the trailing haptic is flexed with the McPherson's and placed underneath the iris. Now to ensure that it is underneath the iris and the haptic has entangled, you can see the surgeon pulling and showing you that the lens is lifting up. Then with the help of Hoagland's hook again, externalizing both the ends. Adequate length is got, and then you trim it. The care must be taken for whenever we use the Hoagland's hook and go inside and come out. It should be very convenient for the instrument to go in and come out, because it can always cause a DMD at the side port side. And as well as it has to be a little larger side port, so that even when you push the knot inside, it should go and settle on the iris. There are occasions where we have seen that knot get entangled within the cornea also. So to avoid that, the side port needs to be convenient for both the instruments to go in and come out. Trim it closer to it. And the other side also, it is repeated. The more important point, like Dr. Divya had mentioned in the morning, that the bite taken should be closer to the, should not be closer to the iris, pupillary margin, because it can cause a peaking of the iris or a cat's eye picture. And then the tunnel is sutured. So like I mentioned, single optic fixation, the best technique to do is always IFIL only. So you can see here, once the complete case has been done, cortex wash completed, lens is placed in the bag. This placement is in the bag. And now, after realizing that the stability is not there, you can see now Madhu sir will do a iris fixation of the haptic on the temporal side. Now, when you're doing this, you can easily see the IOL being lifted. This is one indication that you're surely going underneath the haptic and pulling it out. Knots are externalized and tied. And similarly, decentered IOL, again, through the side port, you can see me just aligning the lens properly first. Using a Sinski, I'm trying to rotate it, bring it into the sulcus position. Then the bite is taken from the point which is closer to the haptic between the side ports. You can see it has gone, the suture has passed beneath the haptic. The IOL tilt suggests it. There is no tunnel made here. You can see that no sclerocorneal tunnel, no phaco tunnel. Easy to do. Externalize it and tie the knot. Very easy procedure in order to just stabilize realign the lens in the particular plane. If you have an adequate capsular support, like Madhu sir had mentioned, adequate capsular support on the other side should be there for you to do a single optic fixation of a decentered IOL. So the main challenges that we face can be in the beginning can be slippage of loops, intra decentration, and difficulty in externalizing the loops below and above the iris. The main complications are like decentration, ovalization of pupil, postoperative uveitis, and secondary glaucoma. The bigger advantage of IFIOL is this can be done most often with the same 3-piece IOL that we use and a single 10-0 Prolene suture, which is easily available through oral lab. It is very less surgical time. It is much more easier to learn, and it has low risk of suture exposure or breakage. And I thank Haripriya madam and Madhu sir for teaching me this, and Sudha madam again for giving me this opportunity. Thank you.